Buenas tardes a todos. Good afternoon to everyone. Glomerulonephritis are changing very quickly, and the KDIGO guidelines had continuously been updated with the new evidence, of clinical trial. Today, we are fortunate to have with us a very expert in this field, the Dr. Brad Robin and Dr. Chi Kei Chun.
Yes, and I'm very happy to be here, and I want to thank to this Spanish Society of Nephrology for inviting me to this session. We have a good partnership between both society. I'm the president of the Portuguese Society of Nephrology, and I want to thank to Emilio Sanchez for this invitation. And my task now is to introduce Dr. Brad Irvin. I think it's no need for a big introduction, because almost we know that he is a nephrologist at Ohio State University and director of the Division of Nephrology, vice chairman of investigation at the Division of Internal Medicine, and he was the co-chair for KDIGO 2024 on lupus nephritis. His studies on lupus nephritis and all autoimmune kidney diseases is known, with a lot of publications and citations. And it's my pleasure to give you the floor, please.
All right. Thanks very much. I really appreciate the invitation to be here. And both Chike and I are going to be talking about guidelines. And I find guideline talks very boring, right? Because you guys can read the guidelines and I don't need to read them to you. So I want to talk about how I might incorporate the guidelines into the management of lupus nephritis that we're doing today. And of course, as was just said, this is going to change tomorrow because there's a lot of new things on the horizon. So these are my disclosures, and I work with a lot of companies helping to do trials and develop drugs. I hope you'll find this to be an unbiased presentation. Okay, so this is the initial algorithm. And in the new guideline, we have practice points. Practice points are considered to be valuable to the audience that's reading the guidelines, but they're not necessarily totally evidence-based. As you may guess, for a lot of the things we do in nephrology and most other subspecialties, we don't have evidence to back everything up. But practice points are practical and logical and sort of make sense. So this is an algorithm on the approach to patients with suspected lupus nephritis. And what I want to talk about as we go through some of these recommendations is some caveats. And one of the caveats is the kidney biopsy. So you go through the algorithm if you suspect a patient with lupus might have kidney involvement, and you're looking for some indication that the kidney is being affected. And we suggest you do that at least once a year when the patient is newly diagnosed, and also when the patient has a flare of extrarenal symptoms. Proteinuria is often the basis of our diagnosis. Hematuria is an indicator, but we generally tend to biopsy patients who have proteinuria that's at least 500 milligrams a day and never had kidney involvement before. So I want to talk about that number because it's rather arbitrary. And what we do in our practice is think about other things going on with the patient. And we've started biopsying patients with much lower levels of proteinuria. Now, this is not in the guideline. We're working on this now, but we find that if we see patients with lower levels of proteinuria, there can be actionable lupus nephritis. And I'll just show you data from a review article we put together a couple years ago. And these were, at the time, all of the papers that looked at very early biopsies of patients with lupus who had low levels of proteinuria. And you can see that in the boxes I've circled, some of these patients, this was the very first time they were considered to have kidney involvement. But all of the patients had less than 500 milligrams a day of proteinuria. And if you slide over to the right, you can see the percentages of the pathologic diagnoses that were made in these patients. And you can see that there's a significant number of patients who had proliferative lupus nephritis, class 3 or 4, and a significant number of patients who had membranous lupus, class 5. And if we decided not to biopsy the patient that early, all of these lesions would have indeed been missed. Now, what does that mean? Eventually, these lesions would come to the front, probably. We would then biopsy the patient, but we would be that far behind in terms of having diagnosed and started to treat the patient. My motto is trying to preserve every nephron, and time is loss of nephrons in inflammatory disease. So it's something to think about, and when a patient has lower levels of proteinuria but may have impaired kidney function, or may have hypertension, or may have glomerular hematuria or a double-stranded DNA, or are not of European ancestry, maybe a biopsy early on would be better to lead to earlier diagnosis. We're trying to look at this now in one of our studies with the NIH. Okay, so you diagnose lupus nephritis, and there's a lot of controversy in our field, not in rheumatology. In rheumatology, everyone gets put on hydroxychloroquine and antimalarial. But some of the nephrologists say, well, you don't need to put a patient who has lupus nephritis on antimalarials. I disagree. Our recommendation is that all patients with lupus nephritis be treated with an antimalarial. And this is a high-grade recommendation, a 1C. There's not too many recommendations with a level 1. And there is significant evidence to support this. And here I've listed all the studies that actually show the benefits of antimalarials, and there's studies that show neutrality as well, just to be fair. And then there's specific studies listed below that look at lupus nephritis and antimalarials. And I'll just show you some, in any case, I don't have the data here, but antimalarials are known to decrease the development of lupus nephritis in patients with lupus, increase the response to therapy, decrease kidney flare rate, and decrease progression towards end-stage disease. So if a patient can take an antimalarial, we probably should put the patient on an antimalarial. We have a practice point about glucocorticoids in lupus nephritis, and we say a regimen of reduced dose glucocorticoid following a short course of methylprednisolone may be considered during the initial treatment of active lupus nephritis. And more, we're favoring a reduced dose scheme of using glucocorticoids for many reasons, not the least of which is the toxicity of the glucocorticoid. So when you're using steroids, I think we should all think about why we're using the glucocorticoids. I know that it's traditional to use steroids in lupus and lupus nephritis for almost everything the patients tell you about. My joints hurt, I have trouble breathing, et cetera, et cetera. However, when I think about glucocorticoids, I think the utility of the intravenous glucocorticoid is to control inflammation right now. It's the only drug we have that really takes care of inflammation rapidly and fairly completely within the first few doses. And we suggest that this be given at the start of therapy for proliferative and mixed forms of lupus nephritis, and really dose it in relationship to the degree of inflammation on the kidney biopsy. Now, you're going to say to me, there's no evidence for that, and I'm going to say, I agree with you, but if you have an inflammatory mess in the kidney, it sort of makes sense to go ahead and try to control that inflammation, because that inflammation is damaging the kidney and will lead to resolution with scar and chronic damage. So we no longer use 1 gram of glucocorticoid 3 days in a row, which was the KDIGO guidelines several iterations ago, unless the patient has a very flagrantly, rapidly progressive course and a lot of terrible histology on biopsy. Our usual regimen is 250 milligrams to 500 milligrams each day for 2 or 3 days to get things started. This gives you a range of about 500 milligrams to 1,500 milligrams of methylprednisolone. Some rationale to back this up. If you recall the Rituximab trial that was done in the UK, they gave a 1 gram total of methylprednisolone, 500 milligrams each dose over 2 weeks, that was given in concert with rituximab, and then they used no other glucocorticoid, so no other intravenous glucocorticoid and no other oral glucocorticoid. And even though this was not a prospective randomized trial, the response rates were quite good. The second, of course, is the voclosporin trial, the Aurora trial, which used a very unique and rapidly progressive regimen to get rid of glucocorticoids. I've illustrated what they did with the glucocorticoids in the graph. The graph itself shows the starting dose of oral prednisone and how rapidly it was tapered down to 2.5 milligrams daily. Okay, that was one thing, but they also started out with only 500 milligrams to 1,000 milligrams of prednisone. And you know that the results of that trial were positive, with a 20% effect size over placebo. So these suggest that for many years we've been using too much glucocorticoid. One thing that I find for adherence of my patients is the glucocorticoid is not helping us. They have so many side effects right away with the steroid that it really puts a damper on using other therapies. So one of the things that's really problematic is what dose of oral glucocorticoids do you start with in lupus? So I was part of this study, we did a meta-analysis looking at trial data from a lot of contemporary trials. And this was published last year in Arthritis and Rheumatology. And what these data show is the red line is oral glucocorticoid with different doses, and the top left graph is this. Oh, I guess I don't have a pointer. Anyway, the top left graph is complete renal responses. The blue line is with pulse methylprednisolone, and you can see that there's an advantage to starting with pulse methylprednisolone and then using oral steroids. However, the top graph on the right is serious infection, and the graph at the bottom is death. And I've put the arrows at sort of an inflection point where the rates of serious infection start to go up and the rates of death start to go up. And this is around 40 milligrams of prednisone, or about 0.6 milligram per kilo per day. So in our practice, we've lowered our starting dose. We used to be 1 milligram per kilo per day and slowly taper. And so now we have a starting dose of 0.5 to 0.6 milligram per kilo per day, and then we taper off within the first 3 months to 6 months. Now, this is going to have to be revised from the KDIGO 2024. We gave you all a menu of drugs to use in patients with class 3, 4, plus or minus class 5. I'm not going to talk about pure class 5 because the evidence for pure class 5 is just not very good, and we really need some dedicated trials for pure class 5. But we gave you the choice of mycophenolic acid plus glucocorticoid or cyclophosphamide in the Eurolupus low-dose format, okay? So we know that. And those I'm going to just call dual therapies because there's 2 drugs plus the hydroxychloroquine. And we also said you could use calcineurin inhibitors plus mycophenolate plus steroid, or belimumab plus mycophenolate or cyclophosphamide plus steroid. Triple therapy. The names are terrible. We're trying to figure out better names for that. We didn't distinguish very well when to use and how to use and which one to use. Nor did we make a recommendation at that time to use triple therapy versus dual therapy. If you keep up with this sort of guideline literature, you'll know that the ACR guidelines, in fact, did suggest that we start with triple therapy. And I think we are moving in that direction in nephrology as well. So I will say, here's the practice point that we say: initial therapy with an immunosuppressive that includes a calcineurin inhibitor. I have listed all 3 calcineurin inhibitors. Obviously, we have phase 3 data for voclosporin. I also know that in many parts of the world, if not most parts of the world, voclosporin may not be available, so you can also consider tacrolimus. We tend to use triple therapy in our practice for most of our LN patients: a CNI plus mycophenolate plus a prednisone regimen in a reduced dose and rapid taper. The rationale for this is to gain rapid control of proteinuria, protect the podocyte, and also to treat the autoimmunity. It's particularly useful for patients with a class 5 component. Class 5 is very arbitrarily defined. Think about if you have 50% subepithelial deposits, you have class 5. If you have 40% subepithelial deposits, you still get podocyte damage. You don't call it class 5. So I think, again, our definitions are a little bit arbitrary, and we need to look at the biopsy. It also makes sense if there's a lot of podocyte stress, so a lot of podocyte effacement. It's useful for a high degree of proteinuria. And of course, we can reduce the calcineurin dose if the patient has a chronically damaged kidney or reduced GFR. So does everyone need triple therapy? Probably not. This is a real problem, is trying to decide who needs to be treated more aggressively. I would suggest to you that very mild disease, mild podocyte effacement, preserved kidney function, no chronic damage, low-grade proteinuria, maybe you can use a dual therapy regimen. It may also apply to very early kidney disease, like with proteinuria less than 500 milligrams a day that I just showed you. However, if you already have chronic damage to the kidney, you know that each flare results in more chronic damage to the kidney, pushing you on a progressive course toward needing kidney replacement therapy. This is some data that working with one of my colleagues in Argentina, and what you see is 3 biopsies. A biopsy at the start, 0 months, 9 months after traditional induction therapy, and then over time, a biopsy at about 45 months. And what I want you to see is that this is the chronicity score going up over the first 9 months despite high-dose mycophenolate and high-dose NIH cyclophosphamide as the induction regimen. So even when you're treating patients really well, and these patients by and large did really well, you are subclinically accumulating damage. So you want to reduce this possibility as much as possible. So that may be where the triple therapies come in, to preserve as many nephrons as you can. Here's some benefits of the calcineurin inhibitor. On the very left is a mouse model, the MRL-LPR mouse, that was treated or not treated with tacrolimus after the disease started coming on board. And if you look at the very bottom picture, you see that the disease control, the mouse that got placebo or no tacrolimus, there's foot process fusion, and you see nice preservation of the foot processes in the mouse that received the calcineurin inhibitor. So we're likely benefiting the podocyte. We have very rapid control of proteinuria. That's the middle panel. You can see that we have a 50% reduction in proteinuria in the blue line with the voclosporin-treated patients very rapidly from the start of therapy, and this was from the Aurora trial. And on the right is just a diagram to illustrate what you all know, which is a lot of proteinuria is toxic to the tubulointerstitium. As the tubular cells take up proteins, they set off an inflammatory program as well as a profibrotic program, and this can cause tubulointerstitial inflammation and fibrosis. So there's a lot of benefits from controlling proteinuria in and of itself to the kidney parenchyma. And I think many of us believe, but there's not a lot of data, it turns out, that a very rapid or early response portends a better long-term prognosis for the kidney. This was a single center study. It was incident cases of lupus nephritis, all biopsy proven. They had a very long follow-up, and they defined renal remission as indicated there with a proteinuria less than 500 milligrams a day on 2 occasions. The median time to renal remission in this particular cohort, and this was by and large a Caucasian European cohort, was about 7 months, but you see a very broad range there. Early and late remission, a cutoff was taken at 7 months. If patients remitted early, so 7 months or earlier, those patients by and large did pretty well. You see a preservation at the end of GFR, and the percentage of patients who developed end-stage kidney disease or chronic kidney disease, GFR less than 60, was very small. It was about double, and you can see a reduction in GFR in the patients that took longer to respond. So something to keep in mind. We want to get things under control as quickly as possible and not let inflammation carry on. So some of you may say, well, you're not being fair. You're not saying, why not use a triple therapy with belimumab? So again, to be transparent, I work with both of these drugs and both of these companies, and we do have a practice point, a triple immunosuppressive therapy with belimumab, glucocorticoids, and MFA or reduced dose cyclophosphamide may be preferred, especially in patients with repeated flares or at our high risk of progression due to severe chronic kidney disease. And I like belimumab more as a maintenance therapy. Why do I say that? First of all, here's the graph of belimumab versus placebo in the S.E.N trial and when the curves started to separate. So belimumab is not very fast acting. It takes a really long time to start to see the separation between control and the treated patients. And I just sort of said our philosophy is try and get the disease under control as quickly as possible. So that's a reason. The next reason is if you look at all the patients that were put in the S.E.N trial, lupus nephritis flares were minimized in all categories of patients, even those with pure class 5. This is really an important finding. We don't see a lot of drugs that prevent flares going forward. This has been found for severe flares in non-renal lupus with belimumab, and we have a lot more experience in non-renal lupus with belimumab, and now we see this in patients with lupus nephritis. The other thing is you can see that the eGFR slope, it didn't reach statistical significance, but the study wasn't powered to look at this, but we did this anyway. We looked at this anyway. eGFR slope in the placebo group is -3 and about -1 in the belimumab group. Okay, I'm almost done. It's critical, the expectations for early therapy. It's critical to monitor patients frequently during the first few weeks of therapy. The expectation is that if you're on an effective therapy, the patients start to show improvement within the first 2 to 3 months. We look for trends in serum creatinine. We look for trends in GFR stability. We want to see improvement in GFR if it was abnormal and not fixed because of chronic damage. We look for improvement in complement, and we look for a reduction in anti-double-stranded DNA antibodies if present. Most importantly, we look for a decline in proteinuria of at least 25% from baseline at the end of month 3. Now, I'll throw a question out that I'm not going to answer, but we can discuss it in the question-answer period. Is this metric still a reasonable metric to think about in the era of advocating calcineurin inhibitors starting right away for lupus nephritis? Something to consider. If expectations are met, we move on to maintenance therapy, and we say that we recommend mycophenolate for maintenance therapy. That's a 1B recommendation. However, in the era of triple therapy, what is maintenance? We used to have what we called an induction period and a maintenance period where things changed. In the Nobility trial, in the Aurora trial, and the S.E.N, patients got kept on the same thing for 2 or 3 years. So we have to rethink what maintenance means. As a practice point, the total duration of immunosuppression plus maintenance immunosuppression should be about 36 months. This is sort of where we've settled. I think the data are not necessarily conclusive on that. If the patient's doing well, our group does aim for about 3 years of total immunosuppression. The first medication we discontinue, as I indicated, was steroids, and then we try to remove the calcineurin inhibitor. If we're using steroids to treat inflammation, hopefully the inflammation is resolved, and if you're controlling the autoimmunity, you should not be acquiring new inflammation. The second one is the calcineurin inhibitor. If you've treated this well and you've turned off deposition, subepithelial deposits, presumably the impetus for podocyte injury has gone away. The other thing is, in the 3-year-long calcineurin trial, about 20% of the patients had to come off therapy, and about 50% of the patients had to reduce. And then the last thing we take off is mycophenolate. If expectations are not met, we have a little algorithm here, but I will tell you that point number 1 is, as you well know, the major problem with treatment resistance in lupus. It's not that the drugs don't work, it's that the patients are not taking the drugs, or the drugs are not being given in a correct dosing regimen or a sufficient dosing regimen, so you need to look at that. So, the end game of this, and I'll be done, is we want to try and get patients off immunosuppression and glucocorticoids, leave them on antimalarials, because if you withdraw antimalarials, patients tend to flare, and the flares can be quite serious. We monitor the patients very closely for flare, and then we continue to treat patients who have chronic damage to slow the progression with SGLT2 aldosterone antagonists. And I have not used GLP-1s yet, but that's probably coming to our armamentarium soon. Thank you very much.
Thank you, Dr. Robin. You're going to have some time after the end of the session. Yes, please.
Thank you. The next speaker will be Dr. June. This is a consultant at hospital in Leicester in United Kingdom. His work lies on clinical trials in glomerulonephritis disease, especially in IgA nephropathy. For that is he with us today. Thank you, Dr. June. When you want.
Thank you very much. Thanks for the kind introduction. And real pleasure to be here today. Thank you very much again to the organisers for this invitation, to KDIGO for putting on this session. So I'm going to talk through the new IgA nephropathy guidelines and some of the rationale that was behind the update. As you know, this was updated only about a month ago, but it spent around 9 months, I think, in public draft, for which there were plenty of opinions about the guideline as well. These are my disclosures, again, working across companies in several of these clinical trials. And again, highlighting what Hiddo Heerspink said this morning, I think Spain has played a really important role in recruiting to these trials across all these glomerular diseases, especially IgA nephropathy. So special thanks for that. So I'm going to start with the case history. There's nothing really very special about this case. Probably a case that may be very familiar to many of you. So this is one of my patients, a 34-year-old woman with a history of asthma, migraines. She saw her GP or primary care physician because she saw some blood in her urine after a upper respiratory tract infection, a cold. And then her GP took some blood tests and found that her EGFR was just 46 mils per minute, where it had been normal last time she had blood taken around 4 years before that. She was hypertensive, she had blood and protein on her dipstick, around 3 grams of protein on a spot UPCR. She was started on ramipril, which was titrated up to maximum dose, which had some modest effect. She was referred through and had a kidney biopsy, which confirmed the diagnosis of IgA nephropathy. 9 glomeruli, 3 were globally sclerosed. All the other glomeruli showed some evidence of mesangial hypercellularity, some endocapillary hypercellularity as well, with a MESI score M1E1S1 T0C0. She had mesangial IgA and C3 on there as well. And then we put our factors into the risk calculator. This is available on our app or on this website, qxmd.com. This predicts the risk of 50% decline in kidney function or kidney failure up to 7 years. And her risk was around 30% at 7 years. I think that's one important point, is that the risk calculator is very accurate for a short-term prediction tool, but really we have to be thinking about this patient's kidney function for the rest of her life. She's only 34, and we have to think beyond that 7 years and how we're going to preserve that completely as well. So what could we offer back in 2021? These were the previous guidelines, and there wasn't really very much. We could consider enrollment into a clinical trial. There were lots of very promising trials at that point. We could think about steroids, but we all know that they're associated with significant risks and toxicities. But since then, we've had approvals for SGLT2 inhibitors for non-diabetic CKD. We've had approvals, I think, just very recently in Spain for Kinpeygo, targeted release budesonide, sparsentan, and in the US, they have also availability to iptacopan and atrasentan as well. So I think one of the key changes that's translated through to the guidelines is this recognition of a high long-term risk of kidney failure and IgA nephropathy. For those who are not familiar with this, this is data from the UK RADAR cohort, which enrolled a large number of adults, 2,300 adults, 140 children, and then to enter into this cohort, you had to have biopsy-proven IgA nephropathy and proteinuria above 0.5 gram per day or an eGFR less than 60. So it doesn't include patients, for example, with just isolated hematuria. And you can see here the lifetime risk of kidney failure is very high. So most of the cohort, over 80% of adults reaching kidney failure within 30 years of their diagnosis, over 50% of children. So if you think here with our case, we're predicting risk up to only that initial 7 years. But I think, we have to think about the risk of kidney failure within lifetime as well. And this on the right shows a link between proteinuria and risk of kidney failure. We know that the higher the level of proteinuria, the worse the risk. But what RADAR showed us also was that even in patients with low levels of proteinuria, time averaged less than 1 gram per day, there was still a 20 to 30% risk of kidney failure within 10 years, suggesting that we really need to aim proteinuria as low as possible. And this was another analysis that came out from RADAR. Essentially, what this showed was that if you are running an eGFR loss between 3 and 5 mils per minute, which is about average for a standard of care in placebo arms of recent clinical trials, you would expect almost all of those patients to reach kidney failure within their lifetime. So really, we need to be aiming that down to as low as possible, at least less than 1 mil per minute per year. And of course, we'll need several different tools to be able to achieve that. And this data has been also mirrored by other registries. This is data from the Swedish Renal Registry, which showed that in any level of albuminuria above 0.3 grams per gram, there was a higher risk of a major adverse kidney event, which was defined by a 30% drop in kidney function, eGFR, or reaching kidney failure. This is a follow-on study from RADAR. RADAR collects data from over 20 rare disease cohorts. IgA nephropathy is the one in green, and you can see the only cohort that progressed quicker than IgA nephropathy was anti-GBM disease in the red here. ANCA vasculitis actually started off with a similar baseline eGFR, but you can see that progression is much slower. Again, I think highlighting the lack of effective therapies to slow down that progression at that time. So we've had SGLT2 inhibitors. This is just data showing progression on SGLT2 inhibitors. They started with a baseline eGFR that's lower than many of the recent clinical trials in IgA nephropathy. So these patients had more advanced CKD. But you can see that despite a benefit above placebo, they're still progressing at around 3.5 mils per minute per year. So again, space for more therapies. But you can see this is a graph that's slightly out of date now from about 3 years ago. You can see that after many years of not very much interest in developing drugs in IgA nephropathy, there's been this huge explosion over the last 5 years. And I think if you go to any conference now, you'll probably encounter a symposium on IgA nephropathy. So we've had these new guidelines, as I mentioned, just published a couple of weeks ago on IgA nephropathy and IgA vasculitis. One of the key messages is to try and diagnose our patients earlier. As I mentioned before in RADAR, the average EGFR diagnosis was only around 45 mils per minute per year. So we really want to be diagnosing these patients much earlier in order to start therapy. And KDIGO suggests a kidney biopsy be considered in all adults with proteinuria above 0.5 gram per day where IgA nephropathy is suspected. And this is the algorithm similar to the previous one. And then defining patients at risk of progression. Here, KDIGO have said, consider patients at risk if they have a proteinuria above 0.5 gram per day, and consider adding in treatment or escalating treatment in these cases. And now they've also defined a treatment goal, and the treatment goal here is to aim to reduce the rate of loss of kidney function down to less than 1 mil per minute per year for the rest of the patient's life, and aiming for proteinuria less than 0.5 gram per day, or ideally less than 0.3 grams per day, accepting that in some patients with extensive scarring that may not be possible, and multiple therapies are likely needed to achieve that. Of course, I can't come to Spain without talking about hematuria, and there probably could be a whole lecture on hematuria. This is data from the Glossen group. I'm sure you're familiar with this, and showing that in patients with positive hematuria, this time measured by microscopy, there was an increased risk of kidney failure compared to those without hematuria, and also an increased risk of a 50% decline in kidney function. Now, hematuria didn't make it into the previous treatment goal. I think talking to Brad yesterday, there was lots of debates about this amongst the working group. And I think, most of the data comes from retrospective studies at the moment. It'll be interesting to see whether there can be some prospective data to generate this and build this evidence, whether it can provide additional prognostic information above proteinuria and EGFR decline. So if we think about the pathology of IgA nephropathy, we all know that there's an increased deposition of IgA within the mesangium, often accompanied by C3. And there's been a lot of work done on that IgA. It's IgA1 in isotype. This differs from IgA2 in that it has an extended hinge region. And that hinge region in IgA lacks galactose from its from certain residues, and therefore it's called galactose-deficient IgA1. And this makes it more prone to self-aggregate, makes it more prone for other antibodies to bind to it, IgG and IgA antibodies, and form these pathogenic immune complexes. So this is known as the multi-hit hypothesis. So we have an increase in galactose-deficient IgA1 with antibody production towards it, immune complexes that then deposit within the kidneys and drives complement activation and damage. And there's a lot of evidence now to suggest that this form of IgA is coming from the mucosal immune system, and especially the gut. So there's multiple agents now in development. The ones in green I've put here are the ones that are approved in different countries, and these target mucosal B-cell priming, B cells by the cytokines APRIL and BAFF, IgA-producing plasma cells with anti-CD38 agents, complement inhibitors, and endothelin receptor antagonists as well. So to start off with Kinpeygo, or targeted release budesonide, this is a specially coated budesonide that's designed to be pH and time dependent release. It releases its maximum dose at the terminal ileum, which is where these Peyer's patches are concentrated, and it undergoes 90% first-pass metabolism, minimizing systemic side effects. In a phase 2 study, this drug was shown to cause significant reductions in proteinuria in patients with IgA nephropathy. And so this has been tested in the phase 3 NefIgArd study. Patients were subjected to 9 months on Nefecon versus 9 months on placebo, and then had a 15-month follow-up period. And here you can see reductions in proteinuria in patients on Nefecon that continued out to 9 months. There was an additional reduction to 12 months while patients were off treatment, maybe suggesting a disease-modifying effect. But once treatment was stopped, that proteinuria started to increase back up to baseline compared to no change here in the placebo group. And you can see here on the right, this is GFR, that kidney function stays stable while patients are on Nefecon, but starts to reduce once taken off at the same rate as placebo. But at the end of the 24 months, there's around a 5.9 mils per minute difference between the two groups in benefits of Nefecon. This is data from the labs here in Leicester showing that while patients are on Nefecon, there was around a 34% reduction in Gd-IgA1 levels, but when that treatment was stopped, these returned back up to baseline. Safety, there were increased numbers of steroid-related side effects, including peripheral edema, hypertension, muscle spasms, acne, headaches. You can see these on the right. More patients discontinued KDIGO compared to placebo. It was around 9% versus 4%. But most of these side effects were generally mild to moderate. There were no serious infections leading to hospitalizations, no increase in fracture risk as well, as opposed to the previous studies of systemic steroids. How about endothelin receptor antagonists? We also have sparsentan available to us. Sparsentan is a dual endothelin and angiotensin receptor antagonist. And we know that once IgA is deposited, both angiotensin 2 and endothelin 1 are released, and they have an effect not only on the renal vasculature to increase glomerular hyperfiltration, but also may have effects, at least from animal models, showing effects on mesangial cells, podocytes, infiltrating immune cells, and on tubular cells as well. So this is sparsentan has been studied in a phase 3 trial. Here you can see patients on sparsentan had a slower rate of kidney function decline compared to the irbesartan group. And it's important to remember in this trial that around 97% of patients on the irbesartan reached maximum labeled dose because this was an active blinded control. But despite that, there was still benefit in terms of kidney function preservation with sparsentan. On the bottom left here, you can see lower numbers of kidney failure endpoints. These are 50% drop in kidney function, kidney failure, or deaths. This result was not significant, but the study wasn't powered for this, but you can see numerically lower numbers compared to the irbesartan group. And here you can see a very rapid and early reduction in proteinuria by 4 to 6 weeks compared to the irbesartan group. Safety as well, quite even numbers of adverse events. There were more incidences of peripheral edema, hypotension, dizziness compared to the irbesartan group, but generally this was very well tolerated and no increases in liver function test abnormalities in this study, as opposed again to other endothelin receptor antagonists that were previously developed. PROTECT was done in an era when SGLT2 inhibitors weren't being used. So this was a follow-on study looking at what happens if you switch patients already on SGLT2 inhibitor from ACE or ARB across to sparsentan. And here you can see that when you make that switch, patients still experience a large proteinuria reduction, indicating that these two drugs could work quite nicely in synergy. And finally, we studied sparsentan as a first-line treatment in a mechanistic study where we had to find patients not on ACE or ARB for at least a year and started sparsentan, and we've done repeat kidney biopsies at week 12, and just to look at the changes on a tissue level. But here you could see quite marked reductions, around 70% reduction in proteinuria by 24 weeks, which asks the question, should we consider sparsentan as a first-line treatment, even instead of ACE or ARB? But I guess that is a question for resources and costing as well. Atrasentan, there's been data from a phase 3 study from an interim analysis showing a 40% reduction in proteinuria compared to placebo, and that study is still ongoing, and the eGFR data should be released, I think, at some point next year. But there's clearly lots of drug development happening in IgA nephropathy, many therapies that are in phase 3 clinical trials and follow-up, so expect more news and more approvals to be coming through very soon. We probably think that there may be 1 or 2 drug approvals every year for the next few years. So causing a lot of excitement are inhibitors of APRIL or BAFF and APRIL. These are members of the TNF superfamily. They act via a shared set of B-cell receptors, the BAFF receptor, TACI, and BCMA. These have important roles in the proliferation of B cells, their survival, maturation, and more relevant for IgA nephropathy, class switching of B cells to IgA-producing cells. So sibeprenlimab was the first, this is probably most advanced in its development. This is a monoclonal antibody against APRIL, tested at a phase 2 study. Here you can see very marked reductions in proteinuria, around 70% by 9 months, that remain sustained. And for the first time, really stabilization of that kidney function with virtually no loss compared to this decline in the placebo group in grey. And here you can see around 65% reductions in Gd-IgA1 levels. And this has been studied in the phase 3 visionary study. I think Dr. Prager presented this yesterday. This was data presented at the ERA showing patients that were on sibeprenlimab experienced around a 51.2% placebo-adjusted reduction in proteinuria at 9 months. And here you can see the UPCR levels falling by 12 months now. Zigagibart is another anti-APRIL monoclonal antibody. Here again, nice proteinuria reductions, stability of eGFR out to 100 weeks. And here you could see in the light blue bar here, these are patients who had positive hematuria at baseline that turns negative. And you can see out to 100 weeks, this increasing over time. Atacicept is a fusion protein that's designed to bind to both soluble BAFF and APRIL. It's been studied previously in lupus, and now it's being studied in IgA nephropathy. Again, out to 96 weeks, the slope of eGFR only dropping to less than 1 ml per minute per year, that target that was mentioned before. So suggesting that maybe with these new treatments, that ambitious target could be achievable. Again, associated with resolution of hematuria. And finally, with anti-CD38 agents, these two CD38 monoclonal antibodies are in phase 3 clinical trials now. This is data from the phase 2 felzartamab study showing that if you give 9 doses over 5 months and then you can stop, you can observe these patients, this has a prolonged reduction in proteinuria and protection of kidney function compared to the placebo group. Finally, complement inhibitors. So we know that the complement system is activated in IgA nephropathy, both the alternative and lectin pathways. This is a driver for glomerular inflammation, not only in IgA nephropathy, but also other glomerular diseases. There has been a trial of a lectin inhibitor of a MAS2 monoclonal antibody called narsoplimab. That was a failed study. So attention has really been shifted to the alternative pathway and inhibitors, particularly of factor B. So iptacopan is the one that's most advanced in its development. There is also an antisense oligonucleotide called S.E.N, which blocks liver production of factor B. That's in a phase 3 clinical trial. And this is data from the interim analysis, again, 9 months, showing a significant reduction in proteinuria, around 40% compared to placebo. And what was interesting, I think, as well, if you looked at the subgroups, there was really no difference in the subgroups according to region, baseline proteinuria, baseline eGFR, SGLT2 inhibitor use, and no difference according to baseline renal histology as well. And these patients entered the trial on average around 1 year between kidney biopsy and study entry. And again, no difference here if you look at patients who have positive or negative hematuria. This is data from the advanced CKD cohorts with eGFR between 20 to 30, again with iptacopan showing a reduction in proteinuria in that group compared to placebo. And there have been some suggestions that obviously complement could play a role in driving tubular interstitial fibrosis as well as glomerular inflammation. This is new press release just from yesterday, showing that iptacopan met its phase 3 primary endpoint in slowing down kidney function decline in the phase 3 clinical trial. Again, we're not sure about the magnitude of that, but it is a positive result. So expect more about this perhaps later on this year or early next year. Finally, there are drugs targeting C5 as well. Ravulizumab is in a phase 3 clinical trial that's now fully recruited for IgA nephropathy. So I've been through a lot, and how can we think about this together? This is a concept that I've taken these slides from John Barrett, and we wrote a review together on this. But you can think of IgA nephropathy as this process where there's this constant deposition of IgA, and there are two contributors to nephron loss. There's the IgA specific component that's driving glomerular damage and loss specifically due to IgA deposition. But once those nephrons are lost, there's hyperfiltration through remaining nephrons, there's hypertension, there's increasing proteinuria that itself can cause further kidney damage. So this part being probably more in common with other forms of glomerular disease. And ideally, we would like to diagnose people before any of that chronic damage has happened, but in reality, we are treating almost two diseases here, an IgA component and a CKD element as well. So we're going to need therapies that can address both of these. So this is where this guideline has really emphasized the change, the biggest shift, I think, that in all patients we should consider simultaneously drugs, therapies that can manage IgA-specific drivers of nephron loss and stopping that synthesis of pathogenic IgA and those immune complexes and stopping that injury, but also managing those generic responses as well with therapies that we're very familiar with, RASI, SGLT2 inhibitors, and now DRAs have come into that category as well. So I think in the past we've been limited really down on this right arm, but the guidelines really encourage us to think about upfront treatment of both these aspects. So these are the statements, so suggesting treatment with a 9-month course of Nefecon for patients at risk of progressive loss of kidney function with IgA nephropathy. Where it's not available, consider a low-dose steroids. ACE inhibitors ARBs, this is a 1B recommendation, but consider also sparsentan or SGLT2 inhibitors as well, and SGLT2 inhibitors in our patients. So the treatment landscape is rapidly changing. I think these guidelines are probably already out of date because we've had approvals for iptacopan and atrasentan, and they didn't make it into the guidelines because those trials were not published at that time. We now have 4 approved treatments specific for IgA nephropathy. There are several others around the corner as well, but there remain several unmet needs. How do we best individualize our therapies? We need better biomarkers, and those populations that were excluded from clinical trials as well. Children, recurrent IgA nephropathy after kidney transplantation, those with more advanced kidney disease, those with rapidly progressive or crescentic IgA nephropathy, and IgA vasculitis. Of course, the elephant in the room is the cost and the availability of new therapies, especially when we're thinking about combination treatment as well. So thank you very much again. Thank you for your attention, and we're happy to take questions at the end.
Thank you, Dr. Xiong. I think we have some time for questions from the audience.
Maybe in the meantime, for you, Dr. Robin, the definition of complete remission for lupus nephritis is very variable between clinical trials. But in any case, do you think that immunological response should be take part of the definition or not?
This is a really important point. I think that we have arbitrarily designated complete renal response. And I think part of the problem is that was done for clinical trials, and there's a big reluctance in modifying that by the regulatory authorities and also by pharma. Let's be honest, because there's a pathway to approval that does not include really GFR slope or a measure of GFR decline. It doesn't include the basics of autoimmunity. And so many of us are, and it's important because all of us in the room understand proteinuria may be our only biomarker right now and maybe our best biomarker, but it's a fraught biomarker. It's got a lot of problems. And so there's a lot of us that are pushing to see if we can actually have a more comprehensive definition of response that will include, certainly proteinuria is important, but histology, the serologies or immunology of the disease, some measures of kidney function. And I think this is really important now in the era of us starting to treat patients with refractory disease, because those patients often have fixed proteinuria that can never, ever meet the guideline of remission.
So in this line, and the question is for both of us, in all the clinical trial, the proteinuria decrease a lot, 40, 50, 60%. But the renal function, in the best of the cases, is stabilized, but in most of the clinical trial, decrease 1-2 milliliters per minute when the result is positive. Do you think this is enough? We should be happy with the proteinuria decreasing, but the renal function not improving?
Yeah, so I think it's a very good point, and it's going to be very interesting to see the data from the upcoming phase 3 trials in IgA nephropathy with these agents that address the pathogenesis in different ways. Some of these agents may be having more hemodynamic effects on proteinuria, others tackling the immunological component. I think there's very exciting data now from the B-cell modulators showing quite a good preservation of kidney function, but this is mainly from phase 2 data at the moment, and we'll have to see whether that translates out to phase 3 and also how long that can be sustained for. But you may start to see different agents with similar proteinuria reductions, but differing effects on kidney function preservation. So that's going to be really fascinating space to watch.
I'm going to take a stab at this. So I think one of the things we have done a very bad job in IgA, and I've been involved in the trials, as you all know, and we do a little bit better job is we are entering patients, in lupus we do a little better job, we're entering patients, especially in IgA, with biopsies that are many years old. And we have no assessment at the time they go into trial of how reversible that GFR is. If indeed there's reversibility, then I think we should try to target a GFR that the patient could have, the theoretical GFR. If there's a lot of chronic damage, Chike's patient, for example, came in with a GFR of 45. This is what we see. They're going down the road, and then they come in with this GFR. You do the biopsy, they've got a T1 lesion or a T2 lesion until we have something that reverses fibrosis. Not stops fibrosis, because that leaves you where you are, maybe. Reverses fibrosis, I don't think we can improve the GFR. I think we have to start, we're working on an editorial, and it's called, in the era of precision medicine, should we have precision endpoints? Does a person come in, and then we decide how good they can be, and that's their endpoint? Now you can imagine the statisticians in the audience are going to shoot me because how you would do this in a clinical trial statistically, but when we do this in real life, that's what we do. We know what the patient has on the biopsy, and we know how much better they can get, and we're satisfied with what they can accrue. So it's an important question, but I think we're thinking about it wrong in clinical trials right now.
Doctora Soler?
Of you for your wonderful presentations. I have a question for Chike. For years, IgA nephropathy treatment has been only for patients with a higher GFR. Why we are keeping 30 of the GFR to thinking of not starting some kind of treatments that could benefit these patients?
So, do you mean why are we not thinking about these therapies for patients with lower GFRs?
Yes.
I think that's a very good question. I think the trials have traditionally enrolled patients with GFRs above 30, and maybe that's more for a safety point of view, but they are starting to include small cohorts of lower GFRs, and those patients are often the most needing of treatments as well. So I think that is a huge unmet need, and hopefully there'll be some data coming through from those cohorts as well.
Thank you.
Okay, and the next question is for both of you. All of old nephrologists like me collect a lot of patients with low-grade proteinuria, and actually we don't perform biopsy because we didn't have anything to give to them. So do you think we should start biopsying all these old patients because they still in our practice and we have to do something? Sometimes could be an IgA or other kind of glomerulopathy, but you don't have genetic testing for everything, so you should keep on biopsy. What do you think on this? This is a practice.
Well, you're asking the wrong person because I think everyone in the audience needs a biopsy too. Yeah, it's a real conundrum because now that we have IgA therapies in patients in whom I've followed for many years with very low level of proteinuria, I agonize over whether I should do something. I think my general answer is I want to know more about the kidney than I do, but to put a patient through a biopsy, if they've had stable proteinuria of low level for many years without a decline in kidney function, I'm pretty much going to leave them alone and not rock the boat. Now, I would like a much better way to assess kidney function than this thing we do called eGFR. And if I could really show that the true GFR is declining, then I would probably go ahead and do a biopsy. But I think we miss a lot with the eGFR or the serum creatinine, as you well know. So that's how I would answer the question. But if I had any inkling that I could do something to help the patient, I would do a biopsy.
Yeah, I fully agree. And I think, we have to make that practical decision. Is that biopsy going to change the treatment in some way? I think that's an interesting point as well about the guidelines encouraging diagnosis with the proteinuria that's with that 0.5 gram threshold, but many of the approvals and reimbursement come for patients who have proteinuria much higher than that as well. But I think in our practice, if we see new patients like this, we like to get the diagnosis up front because we know that many of those are going to progress to that stage eventually.
I think we are out of time now.
Okay.
Perhaps, I'm sure. So you want to finish?
Okay, we are out of time, so thank you very much for your excellent talks, and thank you for the audience to come, so bye.
Thank
Thank you.